Amniotic fluid embolism may cause sudden and unexpected death during labor and shortly after delivery. Although it has a mortality rate approaching 80%, it is rare, occurring in approximately 1 in 25,000 delivery. It is unpredictable, unpreventable, untreatable. There are no convincing identified risk factors in the mother or fetus. We usually present a sudden onset of dyspnea, hemodynamic collapse during labor. Pathogenesis. Amniotic fluid embolism arises from a disruption of the barrier between the amniotic fluid and maternal venous circulation. The complete pathogenesis of amniotic fluid is unknown, but amniotic fluid is believed to enter the maternal circulation through a tear in the plasma membrane and tissue tear in the lower uterine segment. Unfortunately, these tears in the uterine or cervix may frequently not demonstrate at autopsy. The amniotic fluid then travels to the lungs via the maternal venous circulation, where it is lodged in pulmonary arteries. The postmortem diagnosis developed on the histological detection of fetal material within the pulmonary arteries. The mechanism of death is not convincingly known. It is probably related to a combination of factors including reflex vasoconstriction and bronchoconstriction, likely in relation to a vasoactive substance, and physical obstruction of the pulmonary microvasculature. If the woman survives, she is likely to develop a severe consumptive coagulopathy. Evidence of the amniotic fluid embolism can be obtained by antemortem via the demonstration of fetal squamous cells in a blood drawn through a pulmonary artery catheter. Postmortem diagnosis rests on the histological section of the lungs with the demonstration of fetal squamous epithelial cells, lanugo, meconium or mucin in pulmonary arteries. The mucin is from the fetus intestinal tract. Okay. Then a young pregnant woman become dyspnea and hypotensive during delivery. She soon become unresponsive and died despite aggressive resuscitation effort. Amniotic fluid embolism was suspected at autopsy. Examination of the lung slide shows scattered pulmonary artery packed with squamous cells and some inflammatory debris. Okay. Note the absence of nuclei in these cells. Characteristic of desquamated fetal squamous cells. One must not confuse autolytic desquamation of the maternal pulmonary artery endothelial cells with the embolized squamous cell. A useful hint to distinguish is that endothelial cells usually have nuclei, whereas the squamous cell usually do not. Note the nuclei identified in the two sloughed endothelial cells in the same case. Also, one may perform immune histostaining with the cytokeratin, which will stain squamous cells, but will not stain endothelial cells. Note the hair lanugo in another pulmonary arteriole. Mucin is frequently present in case of amniotic fluid embolism, but may be difficult to demonstrate because it does not stain with the routine stainer. One may be suspicious of mucin. The pulmonary arteries may have a clear, distant appearance with a scattered inflammatory debris. The mucin was confirmed by performing an Alcian blue stain, which will stain the mucin blue. Okay, mucin blue. Which will stain mucin. Alternately, a mucin stain could be used. Components of amniotic fluid can be identified in the uterine and the cervical vein. Note the mucin identified in Alcian blue in a uterine vein in the same case. Thank you.